Hello, thanks for watching. Let's talk about gallbladder disease or gallstones. About 10 to 20% of the population have gallstones. That means about 25 million, 35 million people right now with gallstones. The overwhelming majority are asymptomatic and going to remain asymptomatic. About 20% of the people who have gallstones at some point in their lives are going to develop symptoms. Majority totally asymptomatic, unaware of the condition. About 1 to 3% of the general population going to develop gallstones each year. About 1 to 3% of the people with gallstones going to develop symptoms each year. Gallbladder disease is going to be diagnosed more than 1 million times in the course of any given year, and about 700,000 people are going to have their gallbladders removed typically through a laparoscope. Gallbladder is a pear-shaped organ. It sits underneath the liver. It measures about 3 to 6 inches in length. It stores the bile that's manufactured in the liver. The liver manufactures the bile. It goes through the hepatic ducts into the cystic duct and then it's stored in the gallbladder. When the gallbladder contracts, it pushes the bile out through that same cystic duct now into the common bile duct into the first part of the intestine that we call the duodenum. And the pancreas also has a little contribution. The pancreas has a duct, and the duct from the pancreas enters the common bile duct shortly before the common bile duct enters into the intestine. Now, that duct from the pancreas contains the pancreatic digestive enzymes. It has nothing to do with the insulin. The gallbladder stores the bile, concentrates the bile that tends to be dark green to brown, and when food gets into the upper part of the small intestine, then the food causes some of the cells to manufacture a hormone, and that hormone is known as CCK or cholecystokinin, and that causes the gallbladder to contract. Now, the bile itself contains a lot of water, and it contains cholesterol and phospholipids. It contains bile salts and bilirubin. It contains small amounts of protein and inorganic salts that are all necessary to help digest fat. That's how we can absorb fat, and also how we absorb the fat-soluble vitamins, vitamin A, vitamin D, vitamin E, and vitamin K. Gallstones themselves can be tiny as a grain of sand, or they can be like sludge, or they can be the size of a golf ball, or anywhere in between. You can have one gallstone or hundreds of gallstones, and it doesn't seem that the size or the number is indicative of the likelihood of symptoms. What causes gallstones? Well, it's a change in metabolism. Estrogen is one of the primary culprits. Estrogen seems to increase the cholesterol content of the bile, and it also slows down the contraction of the bile. That's why we see more gallbladder disease in pregnant women and women who are taking the birth control pill, especially in the first 10 years of taking the birth control pill, more so than with the patch or the hormone replacement therapy after the menopause. And that's one of the reasons, the estrogen, why we see a predominance in those people under age 40 or so, predominance of women, threefold more so than men. After age 50, the incidence decreases in women to only slightly more than it is in men, but there's still an overall predominance throughout the entire lifetime. Gallstones twice as common in women as they are in men. And by the way, progesterone does pretty much the same thing. And if a woman develops the gallstones while she's pregnant, it's possible that they can dissolve spontaneously after pregnancy. Men taking hormone supplements, the testosterone, they have a higher incidence of gallstones. People who are sedentary increase their risk of gallstones. People who have a diet that's high in calories, high in refined carbohydrates, low in fiber, those people are at greater risk. So too are people who are either overweight or obese, especially if the extra fat happens to be around the abdomen rather than around the buttocks. People who are diabetic are at increased risk because of their insulin resistance and the metabolic syndrome and the increase in the triglycerides and the other lipids. If you go on a rapid weight loss diet or you have weight loss surgery, you're at high risk for developing gallstones. And two, if you weight cycle, you go up and down, you increase the risk. And people who skip meals, for instance, you skip your breakfast, that increases the risk. If you go on a sensible weight loss diet and you lose 1 to 2 pounds a week, that's actually pretty good and can reduce the likelihood of gallstones by about 30%. Overall, the risk is very unusual in children, starts to increase when the hormones are increased. So after about age 15, the incidence goes up. It increases at about the rate of 1% per year in women, about half of 1% per year in men. That continues throughout the lifetime and plateaus after about age 60. There's a significant genetic contribution to the development of gallstones. Overall, it's about 25%. But if you happen to be Hispanic, there's up to about a 50% risk in the family through your genes of becoming a victim of these gallstones. The highest rate in America happens to be in American Indians. American Indian females have about an 80% chance of developing gallstones. American Indian men have about a 30% chance. The incidence high in people of Mexican origin, high in people from South America, and it's typically relatively infrequent in people who are either from Asia or Africa, but as their diet becomes westernized, then they too seem to be suffering an increased incidence of gallbladder disease. If a person takes a statin drug to reduce the cholesterol, that might be somewhat protective. If a person takes a fibrate to help bring down some of the triglycerides, that might actually increase the risk of gallstones. Proton pump inhibitors for your reflux esophagitis, they can increase the risk, but on the other hand, a glass of wine might decrease your risk. Gallstones also tend to be associated with a variety of other diseases. So if you happen to have celiac disease or cirrhosis of the liver, other liver disease, portal hypertension, if you have infection in your biliary tract, if you have sickle cell disease or hemolytic anemia, if you've had part of your small intestine removed, or if you have Crohn's disease or malabsorption, your rate of gallstones increases. And it increases if you happen to have an enlarged spleen, or if you have intestinal stasis, maybe because of diabetes or because of a gastrectomy. And people who are dehydrated tend to have a greater incidence of gallstones. And maybe an insufficient intake of folic acid or magnesium might increase the risk. Now, there are different kinds of gallstones. There are cholesterol gallstones and pigment gallstones and calcium gallstones, and then we have a mixture of all of the above. The incidence is pretty much the way I mentioned them. The cholesterol-containing gallstones are much more frequent than any other kind. Cholesterol-containing gallstones are about 80% of all gallstones. And we diagnose a cholesterol gallstone when the contents of the stone is at least 80% cholesterol. Now, it can be other products too, but at least 80% has to be cholesterol to be considered a cholesterol gallstone. Tends to be relatively yellowish, greenish. Sometimes it could be brownish. Tends to be oval, tends to be solitary, tends to be less than about an inch in diameter, as opposed to the pigment stones. The pigment stones contain bilirubin as their major component. They tend to be darker in color. They can be black. That tends to be associated with chronic hemolysis, maybe cirrhosis of the liver, or it could be brown. Brown tends to be due to the obstruction in addition to infection in the biliary tract. We get supersaturated bile. It sits around for too long in the gallbladder. The body absorbs some of the fluid. Some of those microcrystals get trapped in the lining of the gallbladder, in the mucus. They can form a sludge, and with time, the sludge can aggregate into a stone. So we have the life of a gallstone. It starts off with the lithogenic state, either too much cholesterol in the bile or too much bilirubin. And then over a period of time, we form the stones, but they're asymptomatic the second stage, then they're symptomatic the third stage. Then we can get some complications. Well, about 1 to 3% of the people with gallstones are going to become symptomatic every year. That's what we call biliary colic. It's sporadic and unpredictable, tends to last for several minutes to several hours, but on average, biliary colic lasts for about 30 to 90 minutes. It builds up over about the first 10 to 20 minutes. It's pain usually centrally in your belly. It often follows a heavy meal because remember, the heavy meal is going to cause the gallbladder to contract. So it tends to be in the evening or in the nighttime. Tends not to be really sharp or knife-like. It tends to, at some time, radiate to the shoulder. It disappears when the contractions of the gallbladder stop after the food is digested, after the food passes through that portion of the intestine. Sometimes people develop nausea and vomiting. You don't develop any fever. Biliary colic can sometimes come on without any regard to having eaten. Sometimes the symptoms can be actually quite severe. Oftentimes it's not even diagnosed. It's thought to be, well, maybe I had an upset stomach, maybe it's something I ate, maybe it was gastroenteritis, a virus infection, maybe it was food poisoning. Well, there's a problem, because sometimes people who have gallstones also can suffer from a variety of other ailments. So a lot of people experience heartburn or bloating or indigestion or chronic abdominal pain, or maybe they have a lot of gas or constipation or diarrhea, or maybe they have foul-smelling stools, or they can't seem to tolerate fatty food, so they go see the doctor, and on testing, it's found that they have a gallstone. So now the question is the gallstone that we know 25 million to 35 million people have, is it related to the symptoms that you're complaining about? Or do you happen to have gallstones and you happen to have symptoms from something totally different? Well, unfortunately, it's very difficult to tell at times. So often the gallbladder is removed, and about 60-70% of the time, the symptoms go away, but that means about 20, 30, up to maybe even 40% of the time, the symptoms remain, which means that the symptoms were unrelated to the gallstones. Maybe it was related to gastroesophageal reflux disease, heartburn. Maybe it was related to esophageal spasm or irritable bowel syndrome, or maybe you really had appendicitis or an ulcer or pancreatitis. Maybe you had hepatitis or even pneumonia. Maybe it was a complication of diabetes. We know when the stone gets lodged in one of the ducts, it could get lodged in the gallbladder, it could get lodged in the cystic duct, get lodged in the common bile duct. No, it can even get lodged in the area, actually the most common area is right where the common bile duct enters into the small intestine. Well, sometimes complications develop. And the complications of gallstones can be quite important, can be potentially life-threatening. Can involve the gallbladder itself, or, because everything seems to be interconnected, the liver or the pancreas or the ducts. So in these cases, it's not just the pain that you suffer, it's also the inflammation or the infection. So then you have either what we call acute cholecystitis or ascending cholangitis with infection, or you have acute pancreatitis. Well, acute cholecystitis is considered a medical emergency, so the pain is more severe. Pain tends to be intense and localized up to the right upper quadrant. Sometimes it radiates to the back, sometimes it radiates to the tip of the right scapula. Can last for several hours so that you can't find a comfortable position. People suffer from nausea or vomiting or fever or chills or sweating or hypotension, sometimes a racing heart. You can't get comfortable. You have rebound tenderness if you even touch your belly. Sometimes, on the other hand, you might have a common bile duct stone. That could be totally asymptomatic, or it could cause some obstruction. If it causes obstruction, then you could have some of the biliary colic, but then you could also, because it's the common bile duct, now it's potentially affecting the liver, so you could have some abnormal liver function tests, and you could even turn jaundice, turn yellow, develop yellowing of the skin, the eyes can become yellow. Then some people can develop some itchiness, and the stools turn light and the urine turns dark. Some people develop chronic cholecystitis. Chronic cholecystitis is when you have repeated episodes of irritation of the gallbladder wall because of the gallstone irritating it, and that leads to ultimately some fibrosis, some scarring down, and the loss of function of the gallbladder. So the gallbladder can become shrunken in appearance, and that tends to be associated with a somewhat increased incidence of cancer of the gallbladder. Or you could have ascending cholangitis when you have both the stone and now you have an infection from the small intestine. Remember, the intestine is full of bacteria. Then you can get the ascending cholangitis, where we look for what's known as the Charcot's triad. Charcot's triad is pain in the right upper quadrant and the jaundice, but now you have fever, and this is a medical emergency too, because you could develop septic shock and die in a relatively short period of time. And of course, when you obstruct the pancreatic duct, you could develop acute pancreatitis. That's severe pain in the mid-abdominal area underneath the breastbone. It's sharp, it's continuous, it radiates to the back, it's associated with nausea and vomiting, and you need treatment relatively quickly. Well, the workup is relatively simple: history, physical examination, a couple simple blood tests, imaging tests, make sure you don't have a kidney stone, maybe a standard X-ray. Ultrasound is really the way we use to make the diagnosis. Ultrasound is probably the best test we have at the current time. CAT scans can be used, but they're somewhat less helpful. We can do some other imaging tests where we use the ultrasound on a tube that we insert into the small intestine and then can peer into or use the ultrasound from there, or we can actually use a scope that has a little basket on it that allows us not only to look into the common bile duct, but actually to go and snag a stone in a little basket. The treatment for gallbladder disease, we could just wait it out if it's not too severe. Sometimes medical therapy is used, but that doesn't seem to be very good. Medical therapy would be, for instance, using Actigall or Kinex medicines that are used to help dissolve the gallstones. Well, they work in cholesterol gallstones if they're relatively small. If they're non-calcified, it takes several months for them to work. And unfortunately, when the medicines are stopped, the gallstones tend to recur. Now, one of the uses of those kind of medicines would be in the presence of an individual who is going to have the weight loss surgery. And if you're going to have the weight loss surgery, we know there's a high incidence of gallstones, so sometimes taking one of these medicines can help reduce the incidence. And by the way, if a person has asymptomatic gallstones, we tend not to do anything. But in the case where a person has what we call a porcelain-type calcification, where the lining of the gallbladder is calcified, or in people who are going to have a transplant, or for certain other medical reasons, then it might be appropriate to go and remove the gallbladder prophylactically. They have extracorporeal shockwave lithotripsy, kind of therapy we use for kidney stones quite frequently. Some people got the idea that it could be used for gallstones. Doesn't seem to work very well. Typically what's done is a laparoscopic cholecystectomy. Through a laparoscope, we remove the gallbladder. The gallbladder is not an essential organ. If the procedure goes well, and if you don't have any complications from the disease itself, then you can often go home either the same day or the next day, resume normal activities within a week. If there are complications or if you have to have open surgery, then there's a 5-inch incision. You might be in the hospital for up to a week, and you have to curtail activities for up to a month. Sometimes there's a stone that's lodged in the common bile duct, more common in other countries than in the United States, but that could be dealt with one of those tubes that's passed into the mouth, through the esophagus, through the stomach, into the first part of the intestine, and a sphincterotomy, a little cut can be made in the muscle of the sphincter to allow the stone to pass, and we can just pick up the stone with one of those little baskets. The timing of the surgery, typically it's done relatively early, within 24 hours of the diagnosis. That's typical, even in people who have acute cholecystitis in the old days. Used to be said that, well, let's wait about 6 weeks to cool everything off and then do the surgery when there's not so much inflammation. But now it's found that you can actually perform the surgery within the first week without increasing the complications. If you happen to have a gallstone that's causing acute pancreatitis, you want to get it out, and you want to get it out right now. Complications relatively unusual, but there are about 3,000 cases of gallbladder cancer every year, and about 7,000 complications of gallbladder disease every year. Worldwide, about 100,000 people are going to die every year because of gallbladder-related disease. Now, after removal of the gallbladder, the bile now flows directly into the small intestine. So 50% of the people are going to complain of loose stools or gas or bloating or diarrhea, but fortunately with time that goes away. Some people take one of the over-the-counter diarrhea medicines, anti-diarrhea medicines, they work pretty much. There's a post-cholecystectomy syndrome where after the gallbladder removal, people have continued gastrointestinal distress, they have persistent right upper quadrant pain, and sometimes the cause of that is a spasm of that sphincter right where the common bile duct enters into the small intestine. In that case, again, we slip the tube down there, put a little incision through the tube into the sphincter, and then hopefully all is well. Prevention: have a lot of fiber in your diet, have whole grains, have healthy fats like fish oil and olive oil, keep the gallbladder contracting, cut down on the refined carbohydrates, maintain a normal or healthy body weight, and if you're obese or if you're overweight, try to cut down, lose pound to 2 pounds a week, no more. And if you get exercise, chances are you'll be doing everything that you can do. Then it's your genes and the rest of the world that's conspiring. So, gallbladder disease, extremely common. Typically, it's relatively harmless condition. Oftentimes, when you have biliary colic, going to be misdiagnosed as either food poisoning or a gastroenteritis. Don't even see a doctor. But sometimes when you have the typical right upper quadrant pain, you go see the doctor, gallbladder is removed, and you live happily ever after. Low incidence of side effects. Fortunately, stones don't recur. Sometimes, however, if the gallbladder is removed because you have the stones and you have some other disease, don't know it's another disease, let the other disease persist. So some people, after removal of the gallbladder, can persist with the symptoms, and in those cases, it's one of the diseases I mentioned a while ago. So now you know pretty much what there is to know about gallbladder disease. Hope you enjoyed the show. If you did, why don't you subscribe, tell a friend. Anyway, thanks for watching. I'm Dr. Ken Landau.